Thank you everyone for coming to listen to me talk today. As Gustavo said, my name's Emilia. I'm a PhD candidate at UQ. I'm also a newly minted psychologist, which is really exciting. And as he said, I'm doing a PhD at UQ under the supervision of Stuart, Gustavo, and Ed Heffernan. And Ed actually supervised my Master of Clinical Psychology thesis. And it was for this thesis that I did this review. So the review is titled The Impact of Psychosocial Models of Care on the Mental Health of People Released from Incarceration in Australia. And I also wanted to acknowledge the traditional custodians of the lands on which we meet today and pay my respect to elders past, present, and emerging. And like Gustavo, I'm on Yagara Turrbal land today in Brisbane. Okay, so as I'm sure we all know, people in prison experience much poorer mental health than the general population. There are estimates that 80% of people in prison have a mental health issue. And this poor mental health exists on the background of quite complex psychosocial circumstances before people come into prison. And these are things like unstable housing, financial stress, unemployment, you name it. And unsurprisingly, when people are released from prison, these things don't go away, and often they can get quite a bit worse. Difficulty having stable accommodation, financial difficulties, all those things continue to persist. And we know it's well documented that these poor psychosocial circumstances are linked with poor mental health outcomes, including after release from incarceration. And with that in mind, it's really important that we design responses that are effective and address psychosocial circumstances and poor mental health. And I think, for example, if you think of somebody who's been released from prison, it's very difficult to engage in meaningful and effective primary care, mental health care if you're homeless, if your life is just chaos, to put it in really simple terms. So, what is psychosocial support? Um, this is a term that's used in a number of different ways in Australia, uh, but the Australian federal government do define it as non-clinical, community-based support that helps people manage their daily life, build practical skills, and participate in their community. So, it's a really broad term. And based on the Australian government's funding guidance, there are some key domains of psychosocial support that exist. And among these is social, relational, or cultural support. So for somebody released from prison, that may look like, linking an Aboriginal or Torres Strait Islander person into cultural support in the community, housing or practical living assistance, so helping somebody secure stable housing, even things like learning how to cook, doing stuff around the house. Vocational or educational support, that might look like supporting somebody to identify jobs, apply for jobs, do interviews, all that kind of stuff, engage in training, engage in education. Non-clinical emotional or recovery focused support, that can be delivered, say, by a peer worker who helps somebody kind of cope with stress and difficulties associated with that transition period. And a big one is health and or other service navigation. And that includes supporting people to link into other services that they may need and also just understand the health system and service system better because it's very complex for people released from prison. There's a lot of players in the area. There's a lot of different services, supports, pathways. So that's an important form of support for people as well. And I wanted to make the point, given that the Australian government defines it as non-clinical, I did want to say clinicians also deliver this kind of support. And so that's important to consider as well. It's often delivered in all sorts of different service configurations. So there's some services that have clinical care and psychosocial care. Some just do clinical only, some do psychosocial only. There's various arrangements in place, and clinicians play a role in this as well, but not necessarily. And this is a part where I give a little kind of history summary, and I think it is relevant to this issue and is worth kind of keeping in mind how psychosocial support, how the landscape has developed for people with a mental illness in Australia. So psychosocial care developed alongside developed alongside deinstitutionalization in the late 20th century. And this involved the shift from inpatient psychiatric hospital care for people with a mental illness to more community-based models. However, since that kind of big policy service shift, persistent documented gaps in psychosocial care exist, particularly for people with significant mental health difficulties and also who experience disadvantage and barriers to care. And so the Australian mental health system is very complex, as we all know. There's all sorts of different state and territory funding streams, arrangements, and also federal systems in place as well. One I think it's worth just touching on is the NDIS. This funds psychosocial support for people with a disability. And it's important to note that many people with a disability are ineligible for the NDIS. And the Australian federal government actually commissioned a report exactly on this and found that 250,000 of Australians with a mental illness in Australia in 2023 were unable to access funded psychosocial support. And in this report, they noted that documented gaps exist for Aboriginal and Torres Strait Islander people, people with substance use issues, people experiencing homelessness, and people released from incarceration, who notably, among whom Aboriginal and Torres Strait Islander people, people with substance use issues, people with homelessness are all overrepresented. So I think this demonstrates kind of the level of compounded disadvantage that exists for people released from prison in this area. So what psychosocial support exists for people released from incarceration in Australia? Really the main kind of policy framework is through care, and it's often delivered by or alongside the criminal justice system. I think a key point is that the definition of what through care is can really vary. Commonly, it involves case management, but it does kind of vary from place to place and service to service. Notably as well, eligibility restrictions often apply. That might mean that people with particular needs may be eligible and others are not. And there is kind of a documented evidence of a lack of cultural responsiveness in through care models for Aboriginal and Torres Strait Islander people as well. And there are other services and models of care that exist, but to my knowledge, there was no known review of the effectiveness of psychosocial models in improving mental health after release from incarceration. And I briefly wanted to touch on the fact that implementation factors really matter here too. I think it's important not just to look at mental health outcomes in isolation of how these models of care are delivered. Are they acceptable to people? Are they feasible? How do they work in practice? I think this stuff really matters in translational research that's actually applied in the real world. So with that all in mind, the question that I had is what is known about the evidence for the effectiveness of psychosocial models of care to improve the mental health of people released from incarceration in Australia? And I wanted to note as well, this isn't actually a service mapping study. It's looking at evaluated models of care specifically in mental health. So that kind of is a different approach to a service mapping project. And the sub-aims of this review were to examine what types of evaluated models exist, how have they been evaluated, what are the mental health outcomes examined, how are they defined, how are they measured, and also what do we know about implementation. So this is kind of the boring part. I'm just going to kind of zip through this really briefly. Followed standard scoping review methods. In terms of conceptualizing the review, rather than using PICO, population, intervention, comparator, outcome, I used the SPICE framework, which is slightly different and is often used in kind of translational service-based research. I registered my protocol a priori. You can look at it if you want. It's online. And so I designed my review in accordance with these particular inclusion and exclusion criteria that shape the search and then the screening as well. So I looked at Australian studies only. I focused on adults. Interventions needed to include at least one psychosocial domain, noting that many services will look at multiple domains as part of their service delivery. Comparator wasn't required. And I think something to note as well is the conceptualization of mental health outcomes and how those were extracted and reported on. There's been a real move away from just looking at mental health as the presence or absence of illness. And so I took a really broad approach and looked at clinical outcomes, which I defined as basically that. So, the presence or absence of symptoms in response to sort of clinical treatment. So, non-clinical outcomes kind of look at people's appraisal of their mental health and how they may, address their own mental health, things like subjective well-being, self-care, quality of life. Recovery-related outcomes are quite similar, but are specific to people with a mental illness or a history of mental illness, things like resilience, coping. And then I looked at social and emotional well-being, where key concepts related to the social and emotional well-being framework were extracted, connection to culture, country, community, and other key concepts. The only thing I'll say about the searching is that, we did quite a comprehensive grey literature search. We looked through key grey literature databases, key websites, and tried to be as comprehensive as possible. This is probably not the most interesting part, but I used covenants in Excel, double screen 10%. And with extraction and quality assessment, I did use JBI, Joanna Briggs Institute quality assessment tools, and applied the tools relevant to each included study. And the synthesis was a narrative synthesis, and I really focused on patterns across studies. So what did we find? There were 9 included studies, and as you can see here, there was quite a lot from the grey literature, really at all stages. And of the included studies, they were published fairly recently, between 2008 to 2023. Sample sizes ranged considerably, but this is kind of related to study designs as well that I'll talk about later. There were 5 unique models of care reported. So there were 2 pairs of studies that each reported on the same model of care, but I kind of treated those separately because the description of the model of care changed a little bit, and I thought it's probably worth not making assumptions that things are identical when that's not exactly reported in that way. The quality was quite variable. A common limitation was a lack of reporting around key indicators of quality, small sample sizes, statistical analyses applied that may not have been appropriate, or the absence of appropriate statistical testing, at least from my perspective, lost to follow-up, and sometimes where there were group comparisons, unclear differences at baseline, among others. So as you can see here, pretty much everything came from the East Coast. There were 5 studies from New South Wales. There were 3 from Queensland, and 1 from Victoria. So in relation to what types of evaluated models exist, in terms of how models were described, that ranged quite a bit. There was a housing first program, supported accommodation, short-term transitional health program, service brokerage, and then through care-based models. The actual aim of the model was reported in 6 of 9 studies and kind of focused on housing, skill development, independence, interestingly, not so much mental health. 3 reported kind of an underlying conceptual framework, theory of change, program logic, and none explicitly reported any lived experience involvement in model design. That doesn't mean that there wasn't, they just didn't report it. Most reported pre- and post-release components, and the duration ranged considerably. All reported some duration, from 8 weeks to 12 months and more. And actually just 1 study described the exact frequency of support, the nature and frequency of support at particular time periods. And 2 studies, as I mentioned, there were 2 of 1 particular model, included both clinical and psychosocial support as part of the broader model of care, while the 7 remaining were psychosocial only models. And of the included studies, almost all samples were selected in some way. So for example, there was service for people with severe mental health diagnosis, Aboriginal and Torres Strait Islander people, women, and there was 1 sample that was representative of the general prison population in Queensland. So in terms of the types of domains of psychosocial support included, this slide kind of maps included studies against the domains that I described earlier. And as you can see, the most common type of support provided by nearly all models of care was health and/or other service navigation, followed by housing and practical living. That was very much a focus across most studies. And in terms of who delivered the support, most commonly it was caseworkers or case managers, followed by mental health or clinical support workers, trained research staff, and in one situation, or rather one model, it was, an Indigenous arts officer, elders, community, kind of a more broad approach. There were more people involved than just one provider. There wasn't really a great deal of information reported across studies regarding the level of training required as part of these models, qualifications needed, and no models explicitly reported any sort of peer work provider or lived experience provider. As I touched upon earlier, study types were pretty mixed. There were mixed methods evaluations. There was one RCT, some qualitative studies, and there are a range of data sources as well. A lot of linked health records, interestingly, some qualitative interviews, self-report measures, and the follow-up time period was quite variable, but typically was up to 12 months. So what mental health outcomes are examined? Here I've categorized the mental health outcomes reported against that categorization system of mental health outcomes I touched upon earlier. The most common were the non-clinical mental health outcomes. These were often measured using validated measures like personal wellbeing index, substance use recovery evaluation scale, looking at things like quality of life, self-care skills, and 3 studies reported on mental health service use, which I looked at in addition to these mental health outcomes that I've described. And so what did these studies tell us about the impact of psychosocial support on the mental health outcomes of people released from prison? Of those reporting mental health outcomes, like, again, clinical, non-clinical, recovery, well, no, non-reported recovery, or social emotional well-being, 3 studies reported some kind of improvement in mental health. 2 of those were qualitative, 1 was quantitative. There are another 3 studies where they either reported no change or the findings, there was insufficient information to kind of meaningfully interpret the findings, or descriptive statistics were provided with no statistical testing that made it difficult to kind of draw firm conclusions. Among the studies reporting mental health service use, again, kind of mixed findings, different patterns of findings. One study found, compared to comparison groups, there were lower inpatient admissions in the intervention group compared to the comparison group. One found higher inpatient admissions in the intervention group compared to the comparison group. And another study found more mental health service use at 6 months in the intervention group compared to the comparison group. And something to note is the comparison groups really differed here, which I think could have also influenced these findings. And also not reported was the mental health outcomes associated with this health service use or the quality of that service provision and whether it met people's needs. Okay, implementation. Findings were predominantly descriptive, qualitative. There are a range of different implementation factors covered. The barriers and enablers I think are worth touching upon. I think a key barrier to the implementation of psychosocial models of care was lack of resourcing. So staff often were beyond capacity. I think a key component is navigating that prison environment. As I mentioned, most models of care had a pre and post-release component. Pre-release component typically involves somebody coming into prison and then supporting somebody else or the participant on the way out. Prisons are notoriously very complex environments. There can be a lot of uncertainty around release dates, conditions, access can be a challenge. And at that release time, geographic instability came up as a barrier pretty often. And by that, I mean people being released, rather being incarcerated in an area that's very different from where they live, and then needing to return home, and that creating issues for that kind of ongoing provision of support based on location. And a key one was stigma and mistrust. So through interviews with people released from prison, many felt that um, they'd come in contact with a lot of services before, and understandably, there needed to be a lot of work building trust between the provider and the participant. And sort of conversely, building that trust was really key, was a key enabler to ensuring that models of care were implemented effectively, along with flexible support, making sure that it's voluntary. I mean, that kind of seems like, a bit of a no-brainer, but people really commented on that, being able to opt in and not feeling judged, I guess, which goes hand in hand with that stigma, just having like an open, trusting relationship with the provider. And noting as well, those implementation factors across these studies were not linked to mental health outcomes. This was more just sort of a general discussion of what kind of worked and what didn't. So what does this all mean? Broadly speaking, across all the included studies, um, it was really hard to say who was doing what kind of support was being provided, who it was being provided to, why it was being provided. Descriptions were very high level, and there wasn't a lot of detail that could be extracted about the exact nature, type, duration, frequency, impact of support. Um, with respect to mental health outcomes, look, they were often not the primary focus of included studies. Typically, reincarceration, criminal justice outcomes were primary outcomes. Another thing is that samples varied. So, for example, as I mentioned, there were samples of Aboriginal and Torres Strait Islander people with a serious mental illness. And that means that, different samples may have different mental health needs. They may have different mental health outcomes, and that's something to consider as well with, the heterogeneity of findings. Something to flag as well is psychosocial support. I mean, it's a broad term. They're broad components. And it's interesting that no lived experience involvement was included in the model design, which, could be really helpful in honing in on what do we want to focus on, what's the most useful, what's most likely to work. And this kind of aligns with evidence that models, including that lived experience, peer work support, they can improve engagement in primary healthcare, reduce acute health service use, and also reduce reincarceration as well, like the Transitions Clinic in the US, who've done fantastic work in this area across that country. And with that in mind, I think it's really important that future models do integrate that lived experience, service provider expertise, and also, on the basis of evidence. And that could address some implementation issues as well. And so there is more work coming. Many of you may know about the Health After Release from Prison trial. It's an MRFF-funded project led by Stuart, and Gustavo is the project manager. And this involves three components. One is the co-design of a culturally safe, age and gender responsive model of transitional care, evaluation via RCT in Queensland, and then translation and implementation across other settings. The co-design process is yet to begin. There are some initial thoughts that this kind of model could include GP time, a nurse navigator or Aboriginal health worker, and a peer worker. And my PhD is actually embedded in this project, and it might include some kind of investigation of the design of optimal psychosocial support or some kind of related concept for people released from prison. So it's really exciting that this work is being done. As a brief take home, I just wanted to note, and I hope we all agree, that people released from incarceration deserve high quality and effective care to improve their mental health. And there are so many service providers across this country delivering psychosocial care, and they do really important work to support people released from prison, often in a really under-resourced settings and with a lot of complexity and a lot of challenge. And I think bringing together lived experience expertise, these providers, community, to co-design models of care can help ensure that these efforts have the greatest potential benefit for people released from prison. And yeah, that's it from me. I have a lot of references. There we go.
Brilliant. Thank you so much, Emilia. That was excellent. And I can tell this work is highly relevant to many of us, to many projects, and for example, for the HARP trial and to the work of many people here. Uh, so now we're open for questions. Please feel free to open your cameras. That always makes this session a little bit more personal. If you are not able to share to open your camera or your mic, you can use the chat for questions as well. Emilia, if you want to stop sharing now,
Oh,
that would be
sorry.
great as well.
Thought I had.
Thanks. Please, sure, please.
Great work, Amelia, as always. Thanks so much for your presentation. One of the things I'm curious about is, I'm just keen to get your reflections because you've been in this sector a long time and you understand it. One frustration I have is that I'm sure there are lots of other models out there, and there are probably lots of other evaluations out there, but they're not in the public domain. And it's this perennial frustration that there's a lot of government commissioned evaluations that never see the light of day. I'm wondering if you reflect on that and how, what you think that probably means for your findings and what we should be doing.
That's such a good point, Stuart. Thank you so much for raising it. And I actually do have my full Prisma diagram handy, and I can tell you that there were 30 reports that were relevant that I couldn't retrieve as part of this work, which is really, yeah, really disappointing. And I think that kind of free information sharing is really important. I think as well for services that are doing really good work and would benefit from sharing that. But yeah, it's a tricky one. It does mean that, there's so many providers doing so much work that I'm not aware of that aren't included in this review, which is absolutely a limitation. Um, and yeah, I would just love for things to be more publicly available, but I do appreciate there's a lot of complexity with that as well.
Awesome. Thank you. Lindsay?
Thanks so much, Amelia. It was amazing to hear the work that you're doing and always good to see you. Um, I'm just wondering, so that I was thinking and messaging Sarah Pellicano in the background because this feels so related to some work that we're doing in Perth. We're interviewing service providers that are supporting young people leaving detention and how and trying to understand the challenges that they have and their I suppose opportunities to supporting their mental well-being. And we've got such a rich data source that Sarah has been working through to put together a paper. So there's probably a point of maybe it'd be good to have a meeting and just talk about that in relation to your review. And I might have missed it, but I'm just wondering if you found any studies or if you had an age inclusion. Were there any studies that you found on youth leaving detention, or was it just adults? Um,
Yeah, thanks, Lindsay.
no.
I just focused on adults. I guess because the youth system is quite different, the services available are quite different, but I absolutely think that, an investigation of the support available for young people is really important. And maybe that's another review or project.
Yeah, and again, I doubt there's much that exists if there was just 9 studies that met the inclusion for the adults. But I think one thing that we heard a lot from almost everyone we spoke to was the challenges of accessing young people in detention and the information exchange to support kind of continuity and mental well-being, and a lot of that obviously bleeding into the structural determinants of health, like housing and things like that. So yeah, super interesting. And I don't know if you have any reflections on just based on your, clinical experience and your, knowledge in this area, if you think there would be any differences for young people or other challenges based on what you've seen in this review. Totally okay if that's just outside of the realm of
Yeah,
what you've
I
been thinking
mean,
about.
kind of based on my own experience, I think a lot of the issues are consistent. Issues of, lack of stable housing, lack of, I guess, engagement in education and school. I think the family component is a really big one, having kids engaged with, um, family, culture, connection, all that kind of thing. But yeah, I guess kids are not tiny adults. I think it was George Patton who said that. And yeah, I guess understanding their unique needs and what meets their needs is really important too.
And I think the last thing I'll say that just comes to mind is so promising and great to hear the role of clinicians, but really it feels like an uphill battle when clinicians that are trained and within scope of the time and the resourcing that they have to focus on health, but how do you move the dial on those structural things that are so critical for mental well-being and mental health? I'm sure there's clinicians in the room that might want to comment on that, but I'm certainly not a clinician. Thanks.
Awesome. Thanks, Lindsay. I'm just going to share a couple of questions that we have in the chat now. So Matt is asking, would the lack of detail on descriptions of the supports be due to publishing format, for example, journal articles and tight word counts? And Kate Crawford, so why is the evidence of positive outcomes so thin? Wouldn't trust development be a critical factor to reduce alienation and increase resilience?
Yeah, both super interesting questions. In relation to the question about I think it was around word count and how that might lead to really brief descriptions. Maybe that's entirely possible. Quite a few included studies were reports from grey literature, which, tend to be or can often be longer. Um, I mean, I think part of it is that many of these models of care, what each individual gets may be quite different, and so it can be kind of hard to summarize exactly what's going on for who. Um, and yeah, I think there might be a difference between kind of research and more practice, where I guess the level of detail expected may vary as well. I just think, more detail would be wonderful, including to allow investigation of what particular factors are the most helpful and for who and for why, including investigating some sort of dose-response relationship. I think that would be great as well. But yes, it is entirely possible that things like word count, the purpose of the report, may kind of impact how things are described. And sorry, Gustavo, what was the second question? Can you remind me?
Sure, yes. So the second question is about why the evidence of positive outcomes is so thin. Wouldn't trust development be a critical factor to reduce alienation and increase resilience?
Yeah, no, it's a really interesting question. And I completely agree that those sorts of enablers are really key to improve things like resilience. I guess these things weren't really investigated. I think I might have mentioned that the implementation factors in mental health were not so much linked in the available.
Do you think, sorry to interrupt you, but do you
Hmm.
think these are probably methodological flaws or gaps?
Yeah, I think so. And there's a number of reasons for why that might be. One is that I think for most of these included reviews, like the primary outcome of interest wasn't mental health. It was often to do with criminal justice outcomes. And yeah, lack of resourcing, small studies, um, yeah, may mean that, kind of firm, robust evidence is harder to get in these areas. But look, there was some promising evidence. And I think noting as well that it's hard to compare these studies directly because the services and the people that they were targeting were so different. So, for example, if you have a service for people with severe mental illness, their needs and outcomes are not necessarily directly comparable to another, like a general population group, if that makes sense. There's a number of reasons why that might be. Um, it's a good question.
Yeah, that makes totally sense. Bridge, over to you.
I was actually wondering if the studies were granular enough to differentiate between outcome between men and female post release. I'm suspecting that both populations have very, very different needs and would in fact respond differently to those interventions. So I don't know if you could capture that in your research.
Yeah, thank you so much. That's such a good question, and it's so important. In short, no, it wasn't possible to explore differences between men and women, but I completely agree with you. I think the needs can vary a lot, particularly when it comes to psychosocial support. One thing that comes to mind is how, women released from prison experience really high rates of domestic and family violence. There's a strong link between domestic and family violence exposure and mental health. And so I think the psychosocial care component there is really key. And I think it's important as well that we don't, and which has often been the case, that findings have been based on men and generalized to women. And it's just a common thing in this area I think we need to do better in. But yeah, I'd love to know what kind of differences between women and men may exist.
Thank you. Just another reminder, if you're comfortable, please feel free to open your cameras. It always makes a little bit less impersonal. Emma?
Hi, thanks, Emilia. Thanks, Gal. Thanks for the brilliant presentation. I was just interested in, given your review that found this, psychosocial models show promise, but are often very poorly evaluated in Australia. I'm just interested in your reflection of what would you see in terms of the most important kind of minimum standard for future evaluations of, post-release models of care in Australia. And I think particularly ensuring that that measure of mental health and cultural safety and implementation outcomes rather than just looking at more recidivism kind of angle.
Mm.
Yeah.
Yeah, thanks, Emma. I mean, the immediate thought that comes to mind is that I think when models of care are designed, it's ideal for evaluation to be considered alongside the design of these models. I think that's an ideal way to make sure that the way we're evaluating things is going to capture as much useful information as possible. But obviously, that's not always the case. I mean, there are things that already exist and need evaluation. Um, yeah, I mean, I think linked data is really cool. As everyone knows, I love linked data. I think looking at health service use through available records like community mental health, hospital, ED, ambulance is really good stuff. But also primary data collection is key as well for people that don't come in contact with health services. I think thinking also where possible beyond just mental health as symptoms of depression versus no symptoms of depression can be really good. Like there are those measures related to well-being, life satisfaction, that might kind of help paint a picture of people's mental health. And I think there's a real role for quality mixed methods research in this area as well. So looking quantitatively at mental health outcomes and also considering that in the context of people's stories and themes and what they're saying about their mental health and their experiences.
Fantastic, thank you. And I'm so excited to talk to you more about this.
Thanks, Emma. Likewise.
Awesome. A few more questions are coming through the chat. So John is asking if you came across any studies looking at which psychosocial support would be most helpful or useful for people leaving prisons.
Yeah, thanks, Joan. That's the question I had on my mind. I'm just thinking, like, what is most helpful? What's really worth investing in? In brief, no. I didn't come across studies that identified what's most important when it comes to mental health outcomes. I will say that most had a focus on housing, which I thought was really interesting and which makes total sense given the link between housing and mental health, including for people released from prison. But I would love to know the answer to your question. And my thinking is that in order to kind of understand what's the most helpful, I think that's where consulting and co-designing solutions with people with lived experience, their carers, their communities can be really valuable as well to hear directly from them. What are the hot button issues? What do we need?
Awesome, thank you. Over to Shorts, New Zealand.
Hi, thanks. Thanks. Really enjoyed your presentation. Thank you. Look, I know this is obviously coming from New Zealand. Our Minister for Corrections over here famously said back in April that corrections is not responsible for housing. It's not a housing agency. But one of the practical issues is, and forgive me if you mentioned it and I missed it. Did you separate out remand populations from sentence populations? Because if you think 40% of our prisoners are, they're remand, a remand very in and out population, and if it's often very hard, particularly with that group, to predict their release. As a clinician on the ground working with it, you think you've got people coming to a clinic and then lo and behold, they've gone, they've moved, or they've been into court, and they're lost to the great blue yonder before you've had a chance to actually do anything about it. So whereas for the people on parole, those who've got been sentenced and got sentences longer than 2 years, often it's much more. You can start to plan more. So that was my question. Sorry, did you separate out remand and sentence, and if you noticed any difference between them, and how we might address that, because I think corrections can actually help us out on this a bit.
I couldn't agree more with everything you've said. Unfortunately, I couldn't actually disaggregate between people on remand, or people, who were recruited on remand versus people who were sentenced, because studies just didn't report that. Most didn't. And it is a really important issue. I'm sure others could jump in as well, but I understand in Australia, for people on remand, it's very difficult to access appropriate transitional care, and often it just doesn't happen, which is a real barrier, and I guess contributes to that cycling in and out if your psychosocial needs and mental health needs aren't being met. And as you say, people released on parole, where this sort of support is delivered by corrections, that might mean that there's some sort of engagement, but for people who are, straight released, that can just end up in the ether with nothing, which is a real concern. And I think speaks to the value of these sorts of services being provided through other sorts of agencies as well.
Thank you. One more question from the chat. David is asking, how far along the publication pathway is this project?
I'm currently preparing a manuscript for submission, hoping to publish it as soon as possible. And hopefully when it gets published, I'm very happy to share that around if anyone's interested.
I'm sure lots of people here will be interested. And on a similar note, are you happy sharing your slides?
Yeah, absolutely. Happy to.
Yeah, should people just reach out to you?
Yeah, that's fine either way.
Thank you. I got a question. So most of the studies that you included in your review, they were reporting on programs that were focusing on specific populations. And in comparison, we have, for example, the HARP trial, which is proposing to develop a model that will be very inclusive to everyone coming out of prison. How do you see these differences, and do you think there are any tensions on developing a model that is so inclusive, any limitations, or how do you see these different approaches?
Thanks, Gustavo. That's a really, really interesting question that I have thought about quite a lot. My review evidently focused on mental health outcomes and how these sorts of psychosocial supports can influence mental health. And my thinking comes back to conceptualizing mental health not just as having a disorder versus not having a disorder. Everyone has mental health. Everyone has mental health status. And I think these sorts of supports in place for everyone is probably going to help their mental health. It's about, Maslow's hierarchy of needs, getting your basic needs met. I think anyone can benefit. And so I think being able to offer something to people that doesn't have like a high barrier to entry and doesn't mean that, a lot of people are excluded is the most likely way to have kind of a tangible, sustained benefit. And I think this is often the case in this area with all these inclusion-exclusion criteria. I understand why that exists. There are funding barriers, limitations, contracts that are contingent on particular conditions. But I would love to see kind of universal approaches to supporting people released from prison, because the needs are really there, even if you don't meet particular specific criteria. I'm not sure if I answered your question or if I just
You did, and beautifully said. Thank you. Would anyone else have any more questions or comments or reflections? Stuart, please.
Sorry, I just got one. It's kind of a comment, and I mean, I'd love to hear your response to it. I'm just reflecting on the fact that we're talking about, I suspect a lot of those evaluations, you said you couldn't tell who was in remand. It may be that some of them excluded people in remand. I mean, we've done research on people getting out of prison. We've excluded people on remand because it's so hard to know. But I just reflect on the fact that people released from custody on remand who've never been convicted of anything, they've just, all that's happened is the state has profoundly disrupted their lives with no evidence that they deserved any of it. And it just seems remarkable to me that we just kind of go, well, it is what it is. Like, just when you kind of step back and think about it, I just wonder if you could reflect on that with your clinical and your research hat on.
Yeah, I mean, it's really setting people up for disaster. I mean, that sounds really strong. It sounds really dramatic, but I think it is true. I mean, you're just putting people in such a tough situation where, their situation, psychosocial situation and mental health can really deteriorate so much further. And yeah, you do see it happen, and I just think there's got to be a better way.
Thank you, Emilia. I'm just going to read a few comments that we had in the chat. So Devon is commenting on the importance of justice reinvestment. The Justice Reinvestment Network advocates that justice reinvestment has a direct and measurable impact on psycho disabilities among people leaving prison. The justice reinvestment shifts resources away from punitive responses and into community-based supports, which is exactly where psycho disability needs are best addressed. For people living in custody, especially Aboriginal men who have experienced complex trauma, cognitive impairments, ASD, ABI, or chronic mental health conditions, the traditional system offers almost no continuity of care. Justice reinvestment changes that by funding the things that actually stabilize psychodisability. Justice reinvestment improves outcome for people with psychodisabilities because it replaces punishment with healing, stability, and culturally anchored support. It interrupts the cycle that prisons reinforce and gives people the conditions that they need to function safely and with dignity. Yes, that's really important. Emilia, do you have any comments on that?
I think my main comment is that I hope that this is a direction that we take in future. I think addressing all of these determinants of poor mental health also has, impacts. Like people who aren't well, people who are well are less likely to offend. And ensuring that people's needs are met, I think, is critical. And if we do move towards this kind of model, I just think it would just have a really positive impact.
I'm not sure if it's too early to say, but do you have any reflections on recent changes on the NDIS funding scheme that have been announced by the federal government?
No. And actually, this is something I'm really curious if other people have any thoughts, because evidently this is an emerging area, and it does seem like there's going to be quite a lot of cuts to funding. And I understand for children and young people, there's a whole restructuring. It's not really clear to me at this stage what the implications are for that gap of support for people with mental illness. If anyone knows, please let me know because I'm really interested. But from what I can gather, it's all still emerging and it remains to be seen what the impacts will be. But I can't imagine with, big funding cuts and this kind of policy approach, I'd imagine there may be more unmet need, which is a real concern. But I don't know exactly what will happen.
Yeah, I absolutely share your concerns, and I think we need to be watching next what's going to unfold from these new policies, as apparently hundreds of thousands of people will be cut off from any support.